welcome y'all to the finale of our webinar series. This is the 13th one and final one for this year. So this particular webinar series, Alcohol Use Disorder Treatment, is going to be presented by Dr. Lely, that I'll introduce here in just a minute. But as a reminder, this webinar series and the webinar today is sponsored by Vital, Alabama Medicaid, Alabama Department of Mental Health, Project Freedom, and Project APCP. My name is Ellen Robertson, and I'm the APCP Project Director. And I really want to thank you all for attending. Many of you have attended every one. Some of you have attended 5, 6, and some of just one. Today's your first day. So we just want to thank y'all for the attendance, and we will have some more coming the next calendar year, starting around the first of the year. So just a little bit, I know a few minutes about Vital and APCP. Vital, which is what my grant falls under, is a partnership between state agencies and the University of Alabama School of Social Work. And we strive to provide education and training to healthcare professionals, providers, and other professionals, social workers, counselors, dentists, all the gamut that is on today around substance use disorder and all the topics surrounding that. So let's see what the next slide is, Jackie. Oh, yes, myself and any of the planners nor the presenter have any financial disclosures to disclose. So I know I went through that very quickly, but Dr. Lely has some great information that I want to make sure that she has plenty of time to get to. So I'm going to introduce Dr. Lely. She is a board certified general psychiatrist, an addiction medicine specialist, and an associate professor in the Department of Psychiatry and Behavioral Neurobiology at UAB. Dr. Lely received her MD from the Hubei Medical College in Wuhan University and a PhD from the Georgia State University. She was appointed as the medical director for outpatient addiction services at UAB, and she's provided services for patients in both inpatient and ambulatory settings. I've worked closely with Dr. Lely over the past few months, and she is very knowledgeable and brings a great insight into all things substance use disorder. So it's going to be a lot of great information today. So please type any questions that you have during the presentation in the Q&A box or the chat box, and I'll ask her those at the end of the presentation. So Dr. Lely, the mic is yours.
Thank you, Anna.
Sure.
So is my slide good?
Yes, ma'am, they're good.
Okay, great. Thank you. So first, thank everyone to be here today. And we are going to discuss the treatment for alcohol use disorder. I understand that many of you were in yesterday's webinar, which focused on screening and treatment for alcohol use disorder as well. So sorry for the technical issue. I realize I cannot move my slides.
Dr. Lely, you might try the arrow.
Okay,
yep.
It's good. Sorry for that. And I have no financial disclosure. And there's a few learning objectives I will focus on. So first, I'm going to talk about the epidemiology of alcohol use disorder, which is AUD. So I'm going to use AUD most of the time throughout my presentation. And then we talk about how to diagnose patients with AUD. Next, focus on alcohol withdrawal management. The last is to focus on evidence-based medications to treat alcohol use disorder. So this is a chemical structure of ethanol. Probably many of you are familiar with, and we were taught when we were at junior high schools. So in terms of epidemiology of alcohol use disorder, look at the entire world first. So it's very common, this problem actually. So lifetime prevalence is 20%, and 12 months is 8.5%. That's for everyone in all the countries on the earth. Let's look at the data in the United States. So lifetime is 29%. Among these 29%, almost half of them have a severe alcohol use disorder. And at 12 months is almost 14%. And about like 100,000 deaths that is related to alcohol use. And the onset is pretty early, 18 to 29 years old. And all the like race and ethnicities are affected with different rates. So the highest rate is in American Indians, then African American whites and Hispanics. They have very similar rates, around 14%. The lowest is in Asian American, and which is 10.6%. Males and females are all affected, and females relatively low, 10.4%. And however, many research have indicated that for the females, when they start to drink, they tend to show like a tiny scoping phenomena, which is they go to a heavy drink and binge drink very quickly. So which is described as tiny scoping phenomena. And COVID unfortunately affect all the aspects of our life, also affect how much the people who drink. So only like 13% who drink a little bit less compared with the pre-COVID, and 27% have no change. However, more than 60% drinkers who drink much more during the COVID compared with the pre-COVID. So COVID really increased the alcohol consumption among the people who drink. And this is the diagnostic criteria for DSM-5. And in the DSM-5, there are 11 criteria. So I just listed them here. And from the top is 2 criteria, like excessive amount to use and excessive time and efforts to obtain. And on the left side is craving and unsuccessful attempt to cut it down. On the right side is the tolerance and withdrawal. At the bottom is the 5 criteria in terms of consequence of alcohol use, like hazardous use despite all the negative consequences, health consequences, and missed obligations at work, at school, interference with all the activities, and also relationship problems or personal problems. So add them together, there are 11 criteria. And per DSM-5, anyone who meet 2 out of 11 criteria in the last 12 months can be diagnosed with alcohol use disorder. Depends on how many criteria they meet, could be divided into mild, moderate, and severe. I want you to pay attention to the moderate and severe because I'm going to use or not in when I talk about the treatment options. So these are the first like poll questions, and I want probably take a few seconds to give me some idea how comfortable you are when you have to manage the patients with the alcohol withdrawal from A to B and C and D. Thank you.
And please put your responses in the chat box, just A, B, C, or D in the chat box. Dr. Lilly, I'm seeing a wide range of pretty much the whole gamut of the choices. We have a few that are very confident, and then the majority is, I think, C is what I'm seeing.
Okay, good. Thank you, Ellen. So I did this poll question to the other presentation as well, and apparently this group is very similar to the groups I had before. But I will assure you all that you come to the right place. This is the right presentation for you. Hopefully, after you leave the webinar, and you can change C to B or even A. Okay, let's look at our patient. So Mr. R, he presented to you saying that I am still very depressed and anxious. And then this is his HPI. I'm going to read it to you all. So Mr. R is a 58 years old Latino male. He's referred for evaluation to assess his drinking and depression. And he also seeks treatment options. He reports that he started drinking in high school, and he thought alcohol helps him to manage his depression, insomnia, and social anxiety. He had detoxed at the hospital 5 times in the last year, had a withdrawal seizure during the last admission. Last period of sobriety was for 2 years, which is pretty good, about 3 years ago. However, he relapsed, and he currently drinks about a pint a day. He stated that he really has too much, although he admits occasionally missing work due to hangover. Luckily, he has no DUI yet, and the last drink was 3 hours ago before his presentation. So he has a medical history including like hypertension and alcohol withdrawal complicated by seizures. Family history, and the father had AUD. And the social history, he also smokes 1 pack per day. He denies other substance use. He has a job and health insurance, and he recently divorced. Home medication is only HCTZ, but I'm not sure how compliant he has been. So you are going to examine the patients after he reports his stories. And vital signs, blood pressure slightly elevated, heart rate and respiratory rate in a normal range. And you did a physical exam. He's a thin and well-groomed male, but he was anxious and has no jaundice, which is good, and a spinal angioma. And he's tearful and very emotionally in the office. He thought his thought process is kind of tangential, but overall intact and logical. So you run some labs, and alcohol level 230. Also did some electrolytes, potassium, magnesium are relatively low, sodium okay, and other electrolytes normal. And the kidney function is normal, and the CBC normal, except the MCV is elevated. And also you run the hepatic function check, and it did a GGT, AST, ALT, and calculate the ratio, and also did a CDT. So all the biomarkers for alcohol use disorder are elevated in Mr. R. Then you are going to talk about treatment options with your patients. You tell the Mr. R that there are 2 different phases to treat alcohol use disorder. So the first phase is to safely detox him. And the primary goal is to achieve an alcohol-free state in a safe way and minimize his suffering, and also minimize the complicated withdrawal symptoms, and treat some underlying comorbidities. Second phase will go to relapse prevention and also maintenance treatment. The goal, of course, is to maintain his sobriety, and which is a chronic stage. It's not as acute as alcohol withdrawal at all. So the first phase is acute treatment. Second phase is more chronic treatment. That also indicated that alcohol use disorder is a chronic brain disease, like how we treat diabetes, hypertension, maybe for the rest of their life. So how to manage his alcohol withdrawal symptoms? Let's go over a few things. So alcohol withdrawal could occur in 13 to 17% of patients who present for detox. And up to 10% of patients may have to be admitted in a hospital for observation and treatment. For untreated alcohol withdrawal, mortality is pretty high, up to 20%. A few things to consider when you treat patients with alcohol withdrawal. The first is Wernicke prophylaxis and treatment. And I will talk about more on that later on. And then also think about what are the other comorbidities in the patients, including medical, surgical, and psychiatric comorbidities. Then talk about how to prevent or minimize the complicated withdrawal symptoms like a seizure or DT or mental status change. So this is the Wernicke's encephalopathy. Probably many of you have heard of this particular term. It's caused by the thiamine deficiency. You know, in the patients who drink alcohol excessively, they may not eat or they may not take good care of themselves. So easily they could have a thiamine deficiency, which increases the risk for Wernicke's. Even though it's so common and consequence of untreated Wernicke could be pretty bad and can be fatal as well, but on treatment or under treatment is pretty high. It's very common, unfortunately. So you do have like three classical symptoms. One is the confusion. They are disoriented. They may not be alert, or they could be very drowsy and very confused. And ataxia and abnormal eye movement. Some patients may not present with any of these symptoms at all. And some patients may present one or two or three symptoms. So it's variable from patients to patients. However, if you suspect that the patients may have Wernicke's, always go ahead to treat them. So that's like remember, we need to give a thiamine before we give them glucose, and to prevent Wernicke's. And also make sure we correct magnesium, because when magnesium is low, thiamine replacement is not effective. So all the current guidelines from ASAM and APA have recommended initial treatment is better to be with the IV thiamine, because the oral thiamine absorption is pretty low. Also in the patients with the alcohol use disorder, they could have gastritis, which affect absorption. So neither usually ASAM recommend how to do the IV in the first 3 to 5 days. Thiamine has a very short half-life, so recommended to do 3 times per day, and the dosage could be 100 milligram to 300 milligram by IV in the first few days. And then after IV, you can change to the oral, which is 100 milligram every day. So these are the comorbidities we should consider or keep in our mind when we have patients with alcohol withdrawal. So like these patients, Mr. R, we check electrolytes, and he has electrolyte disturbance. And we also ask these questions: how do you feel? And any depression, any acute suicidality, even like psychotic symptoms and the mania symptoms, any dehydration, malnutrition, anemia, and liver disease. Since all of these comorbidities are very common in the patients who abuse alcohol. So come back to our patients, Mr. R, and last alcohol use was 3 hours ago, and alcohol level now is 230, and the heart rate in the normal range, and the blood pressure slightly elevated, but not a big deal. And also he had a history of hypertension, and I'm not sure how he has been compliant with the HCTZ. And he has multiple withdrawal in the last year 5 times, and the last time he even developed withdrawal seizures. And his lab shows hepatic function impairment. So this is what our patients has so far. And then this kind of just like a table give you and what alcohol withdrawal symptoms are, and when do they develop these symptoms after last drink. So let me go over with you the table. So the first symptoms or the kind of patient could present is very like a fine tremor, and it could be anxiety or could be withdrawal or could be both, and also restlessness, headache, and they may have some GI symptoms like nausea, vomiting, and very fatigue, and anorexia or something like that. So the second, after last drink, 6 to 48 hours, they could develop seizures. Usually it's generalized tonic-clonic seizures. And so we have to treat it very aggressively before it progress or when it occurs. Usually, could send a patient to the ICU setting. And third is hallucinations. And the patient could have visual, auditory, and tactile hallucinations in 1 to 2 days. So visual hallucination is the most common hallucinations that could occur to the patients when they are in a withdrawal, and always ask them about hallucinations. And the last is the deliriums, which is the worst complication in the withdrawal, has a very high mortality. So usually patients were sent to the ICU for the observation and the treatment. Usually happens 2 to 4 days after last drink. So patients could be very confused, and all these like seizures, hallucinations, and deliriums could happen in one patient. So make the case very complicated. So this is another like a timetable for echo withdrawal symptoms. And I want to emphasize here about stage 3. So we usually thought like echo withdrawal symptoms usually don't last more than a couple of weeks. However, some psychiatric symptoms or psychological symptoms, including insomnia, depression, fatigue, craving, anxiety, really could last up to 1 year. And I have seen so many patients in my own like practice. The patients are doing fine. They are sober. However, they just have a significant insomnia, and some insomnia can be very refractory. So, which is a bigger risk for them to relapse. So always keep in your mind when in your own practice, ask the patients these post-withdrawal symptoms. Do they have any or not? If they have any, always very proactive to treat all these psychiatric symptoms to minimize their relapse, help them to stay sober. And this is like a tool we use all the time to assess the severity of withdrawal. So the short name is SIVA. I'm pretty sure many of you are familiar with this specific tool. And the SIVA includes 10 questions. I will discuss in details in the next slide. And it's validated in all the settings, including inpatients, ICU, outpatient, and consultations. So also it's free to use. I include a link website here. And basically you can just go to Google to search like MD care. And then it come with a SIVA. And then you can put the symptoms there, and they will come up with the score and tell you the severity of the withdrawal symptoms. So put ASAM, and for the moderate to severe withdrawal, you have to check the patients every 1 to 4 hours. After they are stable, you can check every 4 to 8 hours. But there's no harm to check the patients as often as possible. So these are the 10 symptoms that are assessed by the SIVA and come up with the score. So the agitation, anxiety, auditory hallucinations, and clouding of sensorium, headache, nausea, vomiting, sweats, tactile disturbance, and tremor, and visual hallucinations. So each symptom has a different score range from 0 to 4 or 0 to 7. And it depends on how the patient presents themselves. They could have different score. And usually make sure when you do the SIVA and make sure you do it in 2 minutes or less than 2 minutes. Sometimes my students or my residents do in like 5-10 minutes, which is not accurate at all. And like I said, this really give you the exact score to quantify the severity, which is very helpful. And so the maximum score is 6, 7, and based on the number of the scores can be divided into minimal to mild, and 0 to 8, and the moderate 8 to 15, and the severe is more than 15. And of course, the higher score indicator and more withdrawal symptoms, and also predict the likelihood of seizures and the delirium. So for the patients that score more than 20, you may always want to talk to the ICU people to see if you can transfer the patient to ICU for observation and treatment. So this is another table to tell like when patients have the score on the left side, what you can do on the right side per ACM recommendations. Let me go over the table with you all. So when the SIVA score less than 8, and the patients do not have a risk or they are not at risk for severe withdrawal, and you may not need to use any medications except a PRN, and just provide them supportive care per se, correct the electrolytes and hydration, make sure they eat, drink, and also started to think about relapse prevention. If a patient score like 8 to 18, and you can do 2 different settings. You can consider outpatients or inpatient, depends on what a patient you may have. So pharmacotherapy with benzodiazepines may need to be used. Gabapentin, carbamazepine can also be used as adjunctive, or when benzos cannot be used. Phenobarbital is another option, but phenobarbital probably I like to recommend you to use it when you have experience. If your setting may not have experience, you may want to focus on benzodiazepines. However, if a patient score 19 or higher, and also have a history of severe withdrawal in the past, admitted patient to inpatient is a good option. And usually patients need a benzodiazepine or phenobarbital to control or manage their withdrawal symptoms. And front loading is usually recommended for the better outcome. So let's come back to our patients, Mr. R. You ask Mr. R very open-ended questions, and you tell him, hey, Mr. R, and your blood pressure is elevated, could due to your hypertension or due to the withdrawal or due to the both. You only score 8. However, your hepatic function seems to be impaired. But if you stop drinking for like 2 to 4 weeks or 2 to 4 months, these numbers usually come back to the normal range. So you just explain his situation in a very direct and empathetic manner, very supportive. Patient is doing fine, and hanging on there over next like 12 to 24 hours. And Mr. R and is kind of develop more like symptoms, and his score higher on SIVA, and right now his score is 14. So what is the next step? This is my second poll questions. So what medications will you consider to use to manage his withdrawal symptoms? These are 5 different benzos. So please feel free to choose only one of these medications.
And same as before, please put A, B, C, D, or E in the chat. I'm seeing a few D's, E and A come up. Looks like A, D, and E.
Okay.
biggest choices, most popular.
Okay, sounds good. Thank you, Anna. So let's see what medications is more appropriate than other medications to manage Mr. R. Let me go over a few things. So benzodiazepines are the gold standard or preferred medication to treat withdrawal symptoms. And if hepatic function is damaged or impaired, usually we choose LOT. I think it's easy for me to remember. So lorazepam, oxazepam, and temazepam. And temazepam is not really used that as often as the other two. So lorazepam is used most often among these three. And I would say for the people who choose E, that's the unit that I would choose as well. It's more appropriate given Mr. R's medical conditions. And so non-acting benzodiazepines provide a better control, but it depends on the patients. Some patients may not be appropriate, but most of the time, if non-acting benzodiazepines can be chosen, I prefer to choose that one. And for talk about front-loading benzos in the high-risk patients. So diazepam is non-acting, and which is given the better outcome. So you can always start with 10 milligram and a QID on the first day. You can always go up and come down, and depends on the patient's presentation, their vital signs, your own observation, and the staff report. And when you prescribe benzos for withdrawal, you can do 24 hours interval. And of course, the patients will be monitored all the time, and always can adjust medication every 24 hours. And consider lorazepam in other patients, including like a geriatric population who are older than 65 years old. Also in the patients who are very confused, like altered, and very ill patients. And because lorazepam has a relatively short half-life and appropriate for the patients with liver impairment, and also have 3 different formulations by mouth, IV, and IM, very easy to administer. And gabapentin can be adjunctive to use. We usually start with 400, like 3 times per day for 3 days, then titrate down to 2 times per day, and for 1 day, then titrate once per day, then stop. So usually like 6 to 7 days treatment course if you want to use the gabapentin as adjunctive. Yeah, always correct their electrolytes. That will be very helpful when treated withdrawal. Thiamine replacements, again, for the prophylaxis or for the treatment to avoid, to minimize the wernicke's. And address insomnia. I think it's very, very important for the patient to have a good sleep, especially when they are admitted to the hospital. So ask them how they feel next morning, how they sleep overnight. Eat, drink, sleep are very important to manage the patients with the alcohol withdrawal. And of course, monitor their blood pressure and heart rate and treat appropriately as well. So in terms of like patients should be in the inpatients versus outpatients, when we manage their withdrawal, there's a few things to consider for you to make your clinical judgment. For the patients you think they're appropriate, for the outpatients could be they score low on the SAVA, even though they score high, like 8 to 15, but they never had a previous history of a complicated alcohol withdrawal, and they don't have a serious like medical surgical problems. They don't have a serious psychiatric or other substance use. They have very good social support. They can come to the hospital whenever they need it. They have family, friends who support them. They also have a place to stay at night. And sometimes the patient may even have a supervision in the place. So if you decide to send a patient home without the patient detox, which I do all the time, I will make sure either myself or my nurse will check in with the patients every day to see how they are doing for up to 5 days until they are stable. So if the patients are so sick or ill, you decided to admit them. This type of patients, probably you want to admit them. For example, SIVA score high, 10 to 15, or even higher than 18. And the patient has a history of a complicated alcohol withdrawal, like seizures, delirium, hallucinations. They have major medical issues. They have untreated or symptomatic psychiatric illness, schizophrenia. They also commit with other substance use like crack or ice, Adderall or prescription medications. And they endorse to have acute suicidality or homicidality or psychotic or mania, or they are confused, or they have they have early onset dementia, cognitive impairment. Some of the patients, they don't have any social support. They have very limited social support, and so, or they are pregnant, or they are homeless currently. They have a frequent unsuccessful detox in the past, maybe 5-6 times. So all these, when patients has some or all of these issues, you do want to admit the patients to the hospital to observe and treat them. So our patients, Mr. R, he scored 14, and he had recent alcohol-related withdrawal seizures. And he had 5 times already in the past 12 months detox. So I said, well, I want to admit you, sir, to the hospital so I can closely monitor you and help you to finish your detox. So after he is admitted, I started him with lorazepam because he had a hepatic function impairment. So what are situations or what are patients you want to use a phenobarbital and how effective it is? So compared with benzodiazepines, the phenobarbital is significantly less used when we manage patients with alcohol withdrawal. This does not mean it's not effective. Actually, it's very effective. Just need more experience to use it, to monitor it. And in the past, there's some theory feel that phenobarbital increase the risk of respiration, depression, and intubation compared with benzos. Actually, it's not really true by recent research. And some patients you may not want to consider. These are like 4 type of patients you want to avoid phenobarbital, which is acute porphyria, severe respiratory insufficiency, and severe liver damage. Patients are pregnant or they are breastfeeding. You don't want to treat them with the phenobarbital. So these are dosage when we decided to use the phenobarbital. And there's loading dosage, just like the way we use it to treat the seizures. So there's loading dosage, and you calculate the dosage using the ideal body weight with the height, of course, my height and my weight, and you just use ideal, not the actual dosage. And you administer by the IM, and so you per se if you calculate patients, and so using like a 15 to 20 milligram per kilogram, and you said, oh, for example, these patients after calculation is 100 milligram. Of course, it's not true, but just for example, to be simple. So you give like a 40 milligram the first hour, 3 hours later give another 30, 3 hours later give another 30 until you hit the goal of 100 milligram. But you have to check the levels, make sure they are not too high, they are not too low. And then after that, you can go to the oral for up to 7 days. And then among these 7 days, you are going to start to titrate it down based on the patient presentation, usually by 50% every 2 days. So phenobarbital, like I said, phenobarbital use need some experience. In my experience, is more complicated than benzodiazepines. I prefer not to use phenobarbital in the ambulatory setting, only in a hospital. but benzos I can use in the outpatient setting. So just need more experience, but it's very effective. So our patients, Mr. R, after 1 day of non-resident treatment, he started to feel better and the CVAS score coming back and stable, and in the next 36 hours. And eventually on the 4th day, you finish a non-resident taper, and he is asking for discharge. In the meantime, he asked you what options I have to prevent relapse and maintain my sobriety. Sounds like he's really making his mind this time to work on his recovery. So that's very exciting. So what medications I could discuss offer to Mr. R? So there's 7 different options here, and feel free to choose any options that you think that Mr. R can take to prevent relapse or maintain his sobriety.
So yes, please put those responses in the chat box. And if there's multiples, just, yep, put a comma. There you go, Charles. Looks to be a wide range, Dr. Lilly, a lot of B's and C's.
Good. That's why I put so many options here.
There's A, D, B, C, D, and A. It's all over the place.
That's good. I'm glad. I like to have these multiple choice questions, and you can see how people respond to the same question in their own ways, right? Okay, let's see what medications is more appropriate than other medication for our patients. Okay, let's see. So first, I want to say, why do we use medications? Not because we are providers, because we have good reasons behind it. First, they are effective. We don't use anything that is not effective. And unfortunately for patients with AUD, the relapse rate is as high as 80 to 90% without the treatment or even without the medication management. And the craving, psychological craving really hit our patients. That's also the main reason they relapse again and again. So anti-craving medication right now is become the new standard of the care in patients with the AUD. And so usually you could consider medications after you finish detoxification in any patients, as long as they are motivated, they are interested. And medication could increase treatment retention, which is what we want. But efficacy of medications really is various, depend on the counseling service and physicians monitoring. And so that's also tell us that we probably need to monitor our patients very frequently, or even for the rest of their life, if they would allow us to do so. And the FDA has approved 3 medications, and all of these medications we could use in the office. So these are 3 medications that are approved by FDA, and naltrexone, and acamprosate, and disulfiram. You can see that disulfiram was approved in 1949, so this has been 72 years. But this medication is really underutilized by us. There's a few off-label medications. I'm going to go over each of them. So first medication is disulfiram, which was approved 72 years ago. So the mechanism actually is very straightforward. Is the enzyme blocker. So after alcohol is drinking, is intake, and they were metabolized to the acetaldehyde, and these chemicals or metabolite depends on this enzyme to metabolize and become acetate. However, and when disulfiram is taken, and disulfiram block these enzymes, so this pathway will be blocked, and acetaldehyde cannot be metabolized, will be accumulated in the body. So after it is accumulated, this is the consequence. The consequence is sweating, diaphoresis, headache, dyspnea, flushing, and palpitation, nausea, vomiting, feel horrible, really horrible and terrible. That's what my patients told me. And so because this like a psychological like a feeling or physical symptoms make patients to stay away from alcohols, and can really delay the first drink, but has no effect on craving for disulfiram. And this dosage 250 to 500 by mouth per day. Usually is recommended to start can be as early as 12 hours after last drink, but I prefer to wait a little bit longer to avoid incidents. So 48 hours is more optimal to start. First a couple weeks, patient take 500 every day, and after that, patient can take 250 every day, and very effective in structured environments per se, in a halfway house, sober living place, and all when the patients are incentivized to take it, very effective. Side effects include like a drowsy, lethargy, and a headache, but usually will go away in a couple weeks after the patient's tolerates. And side effects like depression, psychosis, hepatic function impairment are existing, but pretty real. In the patients with liver disease or coronary artery disease or pregnant or breastfeeding, try to avoid. Disulfiram is not a friend in this type of patients. And you need to monitor their liver function during the treatment. So who should take a disulfiram? These are the APA recommendations. Patients with moderate to severe alcohol use disorder has a goal to achieve sober, and prefer disulfiram or intolerant to other medications. Are able to understand the risk of alcohol consumption while taking disulfiram. I want to add a few more things here about the risk. When patients are taking disulfiram, they know they cannot drink alcohol, but there's two other occasions you may want a patient to understand as well, which is hand sanitizer. Especially during the COVID, hand sanitizer has more ethanol than before. So I had one patient who was taking disulfiram, and he was using a little bit more hand sanitizer than usual, and he developed very mild symptoms. So that's the kind of I learned from my patients. Also, in the Italian restaurant, the ingredients has a little bit more vodka or other alcohol. So patients could also have symptoms if they eat in the Italian restaurant when they are taking disulfiram. So I usually tell the patient three things: stay away from alcohol, stay away from high content hand sanitizer, stay away from Italian restaurant to be safe. That's usually I tell the patients. And there's no contraindication to the use of this medication. So these are like APA recommendations. And this is second medication, naltrexone. So naltrexone is a mu-opioid receptor antagonist and reduce the positive reinforcement, so could reduce the craving and suppress the beta endorphin in nucleus accumbens, which is the primary like dopamine rewarding pathway. And so highest the craving, the best effect, and the less impulsive to drink, less pleasure from alcohol use. Efficacy is decrease the craving and reduce the drinking days and reducing relapse to heavy drink. So recommendation for APA is to use in patients who have a goal of reducing alcohol consumption or achieving abstinence. but it's not a kind of naltrexone cannot be taken with full opens. And also, if a patient is anticipated to have inactive surgery down the road, you may want to hold naltrexone because it's a mu opens antagonist and is enemy of opens and could trigger patient to have a perceived withdrawal. So these type of patients you have to avoid. Like I said, very effective, especially in very highly motivated patients. There's one study done in physicians and showed 80% abstinence for 18 months. So it's very effective in highly motivated patients. Side effect could have a nauseation, and elevated liver enzymes. So you need to monitor their liver enzymes during the treatment. If the patient has acute liver damage, per se, their AST like 5 times higher than normal range, you want to hold the medication. Have 2 different formulas, and mouse is 50 milligram every day, but the compliance can be an issue. Then injectable formula every month can be more friendly. So this study was done in 1992. Actually, is one of the landmark study before the medication was approved in 1904. So in this particular study, they focus on the efficacy on craving and compare with placebo, which is the open circle, and naltrexone is a solid circle. You can see that compare with placebo in terms of craving, and the patients who are taking naltrexone has much less craving and compared with the controls. So it's effective to control craving. And the same study also look at the relapse prevention. And again, the open is the control and the solid is naltrexone. And in terms of relapse rate. So for the people who are taking naltrexone has much less likely to relapse compared with the controls. So after this study was published, and FDA was able to approve naltrexone to treat alcohol use disorder. Like I said, this is another formula of naltrexone, which is a monthly IM injection. Another name is Vivitrol. So every month, 380 milligram, and very convenient, better compliance, and sometimes the patient could have injection site reaction, but you don't let it go away in 2 or 3 days. You still need to monitor hepatic function. And the study shows that to reduce the heavy drinking 50% compared with the controls. So effective. And this is a third medication that has been approved by FDA, acamprosate. So acamprosate has a different mechanism from the previous 2 medications, amino acid similar to GABA, and also antagonize MDA receptors. So it's effective just like naltrexone, increase treatment rate and abstinence, decrease relapse, reducing craving, and so especially in the motivated patients. So APA recommend patients who have a desire to reduce alcohol consumption or who has a desire to achieve abstinence. So these patients are appropriate for acamprosate. And different from the previous 2 medications, this medication is excreted by the kidney. So you have to make sure the patient's kidney function is okay. And for the patients who has impaired kidney function, you may have to adjust medication a little bit. Or if the creatinine clearance is less than 30, you will not prescribe acamprosate. It's contraindicated. So this medication needed to take 3 times per day, and 6, 6, 6, 2 tabs over 3, 3, 3, 3 times per day. Total dosage is 2,000 per day. And side effects is sometimes the patient complain diarrhea or pruritus, but it's very transient. So for the patients who have a hepatic function impairment, or who are going to take opioids, and who have a hepatic disease like cirrhosis, and a composite is a consideration. This medication also has very few drug-drug interaction, so appropriate for the patients who are taking many medications. This is one of the study in 1906, and this study was done in 96 weeks, had a 2-phase treatment period and a follow-up period, and look at its efficacy in sobriety. So compare with the controls, and this medication has a better effect to maintain sobriety when the patients were in the treatment phase, and also this is, if efficacy continues and go when patients went into the follow-up period. So this is a study indicated that a composite is very effective to help people stay sober. So there's some other studies to combine 2 medications and to see if they have better effect compared with the single medication. So one of the study was done to combine naltrexone and a composite, and this is a 12 weeks randomized control trial. And in the trial, patients take either 50 milligram naltrexone or 600 milligram composite TID, or both of them, or placebo. So look at this figure, and there you can see there's 4 different curves here. So the top one is a combination of naltrexone or composite, then naltrexone, then a composite. The bottom one is a placebo, and then they observed the patients for 80 days. And during this observation, they found out that for the patients who were taking combo had a better effect in terms of sobriety. So their conclusion is that combination of naltrexone and a composite help patients stay abstinent better than each medication alone. So the idea here is that if the patients failed one of these 2 medications, you could consider to let the patient take both to see if the patients could have a better treatment outcome. So that study is a combined study, which is well known in this field. And so this is a very complicated study, but I just want to give you some idea. Is this study shows that medical management with the medications, especially naltrexone, or with cognitive behavioral intervention, have the best outcome for all the patients. And so involvement of us in the patient care combined with behavioral therapy and the medication have best outcome. That's what we need to keep in our mind when we treat the patients. Because off-label use of gabapentin, topiramate, and baclofen results are very heterogeneous, and they are off-label use. And for the patients who cannot tolerate the other 3 medications, you could consider one of them. So come back to our case. So these our patients, Mr. R, had hepatic liver function, and he's interested in medication management. So I will answer this question myself. I will choose a composite 666 milligrams 3 times per day to help him stay sober. So I will skip some facts since I mentioned it before, and come to my summary. So prevalence of AUD is very high, especially higher during the COVID. And the treatment of alcohol withdrawal can be in both inpatients or outpatients, depending on what the patients you have. And use a SAVA to estimate the severity of withdrawal symptoms. Always consider to use medications after they finish a detox to help them. And always make sure we are involved in the patient care. Consider pharmacotherapy and psychotherapy. However, for the pregnant patients or breastfeeding patients, don't have to treat them until they have the baby or they finish breastfeeding, unless they are in acute withdrawal. Otherwise, this is my last slide. Otherwise, I'm happy to take any questions or any comments you have. And I include my contact information here. Feel free to reach out if I can be any helpful for yourself or for your patients. Happy to do whatever I could for you and for your patients. Thank you so much. I know I'm running out of time. I'm sorry for that. And but please feel free if I cannot answer your question today, and forward your question to my email or to my office number, and feel free to leave me the voicemail. I will get back to any voicemail in like 1 to 2 business days. Thank you so much again.
Thank you, thank you. And for everybody, Dr. Lily's email is in the chat box if you would like to email her. And I do have 2 questions for you, Dr. Lily. One, for those who do prescribe, is there any additional credential certification? So sort of like the X waiver is for opioid, is there anything extra needed for this medication?
That's a great question. I'm glad you asked this one. No, there's no any requirement of certification at all. None of these medications are controlled except gabapentin, which is controlled 5. But in order to prescribe gabapentin, you don't need any special requirement except you need a DEA number.
Okay, great. And my second question is for those individuals who are on here who are not prescribers, what would be their take-home message from your presentation? Because I know knowing information about what will be prescribed is beneficial, but I just wanted to get your thoughts on that. For those who are not prescribers, what would be a good take-home message for them?
I think that's another good question. I think there's like 2 take-home messages for non-prescribers. The first is psychotherapy. Psychotherapy is a very effective person, like a CBT and like a motivation interview, supportive therapy are very effective. So always feel free to offer the patients to offer this supportive therapy, even like curbside supportive therapy. And the second is SPURT. So SPURT was discussed yesterday and was discussed 2 weeks ago by me and Shanna. So SPURT to screen for any patients or any potential patients who could suffer from alcohol use disorder. Actually, the third message is you talk to the provider or prescriber to let them know psychotherapy and psychopharmacology are the best combination to treat the patients with alcohol use disorder.
Great, great. Well, thank you. That's all the questions that came to my mind. But if any attendees have any additional questions, you can email me and I will forward those to Dr. Lely, or you can email Dr. Lely directly with her email address. So thank you so much, Dr. Lily. We really appreciate the great information and look forward to more presentations in the future.
Thank you so much. Have a good weekend.
Thank you. You too. And